I would like to thank organizers for giving me this opportunity. We'll just go through the background. This is what before this trial, what we have data with all IO and IO TKI combinations. Roughly, Sunitinib response rates corresponds to overall response rates 35 to 40, CR rates 3 to 5, and progressive diseases 14 to 17. And over and above, IO did a bit better with respect to the response rates. Overall response rates 40, and IO plus TK, the response rates are a bit more compared to IO plus IO. Take it as Nivo Cabo 55 and Pembro XZ 60, and the best response rates what we have seen with Pembrolizumab plus Lenvatinib, that is 70%. The only problem with IO was early progressive diseases. Roughly you can see 18% of the patients are progressed early. This is the what we have until now. And I just want to skip all these trials in coming discussions. Anyways, we are going to discuss. And this is what the trial, and it's done in China, phase 3, open label, randomized, Toripalimab, experimental arm Toripalimab plus Axitinib, control arm Sunitinib. What other IO plus TK trials until now have did, these guys also did the same. They kept control arm, it has Sunitinib. As we discussed in the morning, maybe they would have changed. But they want to try prove it, maybe this regimen is as effective as the remaining regimens. That's why they kept it control arm as Sunitinib. The experimental arm was Toripalimab plus Axitinib. The inclusion criteria was 80 to 80 years, and histologically proven RCC, whether it may be unresectable or metastatic, and they should not receive any previous systemic therapy for metastatic disease or unresectable lesion. But the only difference what they have taken with compared to the remaining TKI plus IO combination trials was these people have included only intermediate and poor risk. But the remaining all IO plus TKI trials they have taken along with intermediate and poor, they have taken favorable also. But these guys included only intermediate and poor risk. And ECOG performance status 0 to 1. The exclusion criteria, as with same other trials, they have excluded active CNS metastasis and whoever is on steroids equivalent dose of prednisolone 10 mg and poor control hypertension. Endpoints were, primary endpoint was PFS, and secondary endpoints was overall response rate, disease control rate, duration of response, OS. And roughly they have included 420 patients, fair number, and this is the baseline characteristics of the patients. And if you roughly this all patients more or less intermediate and poor risk patients, whatever we are seeing in the clinic, maybe poor risk patients may be more. Here they have taken 20% of the poor risk, and the intermediate were roughly 80%. And sites of metastasis as what we have seen in the clinic, lung, liver, bone, and nephrectomy not performed roughly 35 and performed 65. More or less it is representative what we have seen in the clinic. And those population was equally distributed between the testing arm and experimental arm. Just look at the efficacy. First concentrated on the control arm, how the control arm was performed as compared to the remaining trials. I feel myself like Sunitinib more or less performed same way how it has performed in the remaining trials. Just look at the objective response rates 30%. And the same way how it has behaved in the previously. That's why the control arm, there are no controversies in the performance of the control arm. Coming to the experimental arm, just look at it, the overall response rates were 56, almost more or less equal to the Cabozantinib plus Nivolumab trial. And Pembro XZ 60, Pembro Lenvatinib 70%, this also did same as 55% overall response rates. But the only difference what this drug, this combination did differently compared to the other immune checkpoint and TK trials was CR rates. That is 4% in this. CR rates was only 4%. Whereas if you look at in the remaining trials, the CR rates was corresponds to 15 to 20%. But here the CR rates were a bit less. This CR rate we have seen in the Cosmic trial where they have used Nivo EP plus Cabozantinib. There may be because of 3 drug combinations, some people are not able to take Ipilimumab. That is what they have given explanation. That's why the CR rate was came down in the triplet regimen. But here also we have found CR rates were a bit less compared to the remaining IO plus TK combinations. And PFS, good, hazard ratio 0.65 and almost double PFS as like remaining TK plus IO combination, and investigator PFS also looks good. And left side was intermediate risk. The hazard ratio was 0.67. As expected in poor risk, the combination may bit better compared to the TK. the hazard ratio was 0.56. The significant hazard ratios and the primary endpoint was satisfied. Coming to duration of response, what morning also what we have discussed, the patients who are all getting response, and in those patients whether the response is maintaining or not, that is what they want to see. And the patients who are getting response, they are all maintaining. If you look at the PFS subgroup analysis, roughly almost all subgroup patients are benefiting, but in some areas the confidence it is crossing the unity, but maybe because of the less number of patients, that may not be because of it is not effective in those group of patients. And overall survival still yet to mature, but looking good, significant, not significant, but yet to mature, but the trend was looking good, hazard ratio was 0.61. And subsequent anti-cancer treatments in 50% of the people, what we want to see always, what we want to look was in Sunitinib, how many patients are getting immunotherapy. That's what everybody want to see, and everybody is interested also. Out of 50% of the patients who have taken subsequent treatments, 26% out of those, half of the people roughly out of those 26% have taken immunotherapy. But yet to see the overall survival curves. These are with respect to the treatment emergent adverse events, more or less same what compared to the remaining IO plus TKI combinations. Likely, as we expected, this grade 3-4 toxicities were more with IO and IO plus TKI, roughly 67 and 71. Treatment discontinuation were 8 and 4%. Serious adverse events were, fatal adverse events were almost comparable, 3% and 2%. These are 3% in the Toripalimab plus Axitinib and Sunitinib 2%. There are no new warning signs with respect to this combination. As we discussed in the morning, the common side effects are same: immune-related adverse event, hypothyroidism, hyperthyroidism, rash, and AST/ALT alterations. This is a snapshot what the other trials are doing and what RENOTORCH was doing. The above trials, they have included a favorable also. What I kept the hazard ratios, these hazard ratios are only for intermediate and poor risk, and RENOTORCH is included only intermediate and poor risk. That's why the hazard ratios are same. I will take just 1 minute. The almost equal hazard ratios, and with respect to median OS, the hazard ratio was bit better, but yet to mature. And comparing to PFS, the hazard ratios are more or less equal. And the limitations coming to study, it's an open label study limited to one geographic area. Patients above the 80 years were excluded, and they have excluded favorable risk patients. Short follow-up, no data on quality of life and patient reported outcomes, which was most important, and the overall survival data was immature. My take in this study, almost equal overall response rates, maybe less CR rates compared to the remaining IO plus TKI combinations, fairly doing on par with the remaining combinations, IO plus TKI combinations with the available follow-up. Needs to look at the long-term follow-up data for OS, and there is no hurry to adopt in the early morning with this combination. We can look at the long-term data, and this combo will stay in the race but may not win the race. The time will decide. Thank you.